All right, moving on to Chapter 2, some highlights of cardiovascular physiology. I'm going to start off with a discussion of the venous return curve, and this is the often forgotten aspect of cardiovascular physiology in the intensive care unit. Remember, cardiovascular physiology has both cardiac and vascular determinants of blood flow. We live in a very cardiology-centric world, and they live in a very Frank-Starling centric world, so we often forget about the determinants of the vasculature in cardiovascular physiology, and that's what Arthur Guyton gave to us with this venous return curve. Now let's take a look at the axes here. Like the Campbell diagram, pressure is on the x-axis, and that will be an important concept to remember when I talk about the novel integration of the Campbell and Guyton analyses, is that they share the same pressure x-axis. Here it's in vascular pressures, millimeters of mercury, right atrial pressure. But on the y-axis we have blood flow, and that's the amount of blood flow per unit time. So this is the venous return curve. And this first point here is a critical point, and this is your mean systemic pressure. And you get the mean systemic pressure by arresting the circulation, so you stop blood flow, you bring blood flow to zero, and then you let all of the vascular pressures equilibrate, and then you put a catheter into the right atrium and you measure the pressure, and you get this mean systemic pressure. And this is essentially the pressure that is present in your venous capacitance beds. And it is the pressure in the venous capacitance beds because that is where 70% of your blood volume lies. And remember that when determining a pressure, you take into consideration volume and compliance. And so the mean systemic pressure is really just a recapitulation of the compliance equation solved for pressure. So this PMS, unfortunate abbreviation, is your mean systemic pressure, and it is equal to the stressed volume over the venous compliance. Now the stressed volume, this represents about 30% of your blood volume in a normal, healthy, resting adult. It was measured actually in patients who were about to undergo coronary bypass or open heart surgery, I believe. But you can think of stressed volume like an analogy is like blowing up a balloon or blowing up a beach ball. There is a certain amount of volume of air that you add before the walls stretch, so there's no pressure change, but you're adding volume. That is the unstressed volume. Then you reach a point where it becomes harder to blow up, and that's because you've reached your stressed volume, and that is the amount of volume that's actually causing pressure to change and stretch the walls of the balloon that you are inflating. And the same sort of applies, the same analogy or the same reasoning applies to the venous vascular bed, and that is there's a certain amount of volume when you start to stretch the venous walls, and that's what causes this the upstream pressure. So that your mean systemic pressure is the upstream pressure driving blood flow back to the heart, and it's typically in the normal healthy resting adults, typically in the 8 to 10 millimeters of mercury range. So this is your mean systemic pressure. So this curve can shift rightwards and leftwards. So what were to let's say I took a patient and I gave him 5 liters of crystalloid. Well, I'm going to increase that patient's stressed volume, and therefore I'm going to increase their mean systemic pressure, and I'm going to increase the pressure head for driving blood back to the heart. I'm going to shift the curve rightwards. Okay, so this patient has an increased circuit function or an increased vascular function, and that is for a given right atrial pressure, let's say just +3, this patient here will have this much venous return, and this patient here will have this much venous return. So there's a greater venous return for a given downstream pressure. The right atrial pressure is the downstream pressure. And this is often referred to as increased circuit function, and causes volume expansion, hypoxemia, which is a potent adrenergic response. An adrenergic response increases the stressed volume by acting on the venous vascular beds and compressing them and moving unstressed volume into stressed volume. It's kind of like an auto bolus. And then adrenergic agents that we give the patients, like vasopressors, will shift the curve to the right. You can also shift the curve to the left. And this is known as decreased circuit function, and probably the best example would be patient in hypovolemic shock from diarrhea or blood loss. They've decreased their stress volume even though they try to compensate for it with adrenergic tone. They shift their venous return curve to the left, so the driving pressure for blood back to the heart is lower, so for any given right atrial pressure there will be less venous return than in the patient who is, let's say this patient's euvolemic, this patient is hypovolemic. Okay, volume loss, sedatives, adrenergic antagonists, just the opposite of what increases circuit function. And then there's this last aspect of the venous return curve that I want to talk about, and that is this concept of maximal venous return. So you can see each of these curves has this plateau here and here and here, and as you increase the mean systemic pressure, you actually increase the blood flow at which this plateau occurs. And this plateau is maximal venous return, and it is essentially the generation of a Starling resistor, or the vascular waterfall effect. And a Starling resistor occurs when the pressure within a vascular structure dips below its ambient pressure. So the ambient pressure tends to collapse the blood vessel, and what happens is you get this fluttering effect of the blood vessel, and you can see this when you're ultrasounding a patient's IVC and you see it collapse. Now it doesn't cease flow, the collapse just plateaus flow, because the instant that there's collapse, the upstream pressure then raises relative to the collapse pressure, and then blood goes through again. So you get this fluttering effect and this plateau. And it's called vascular waterfall because the downstream pressure no longer affects blood flow, much like a waterfall. It's just the flow is driven completely by the upstream pressure, not the height of the waterfall per se. And the vascular waterfall was really first described by Saul Permut in the early 1960s with respect to blood flow through the lungs. You get vascular waterfall physiology in West Zone 2. But I'm starting to ramble now. So this is maximal venous return, and this cartoon here is I've made to help illustrate this effect. So this is your IVC, this is your heart, your diaphragm. This patient's kind of lying on their back. This is the posterior and anterior aspect. So if you're to take a breath in, you have this gradient form. The right atrial pressure tracks your intrathoracic pressure, and then that creates a gradient down the IVC into the abdomen. So this P-ab is P abdominal pressure. And then as you inspire, your diaphragm is moving down. You're actually increasing pressure in the abdomen. So your pressure in the IVC is going down, and the pressure in the abdomen is going up. And so then this is the Starling resistor. You start to get this fluttering effect. And you see the IVC kind of collapse and flutter when you look at these patients with the ultrasound. And that's the physiology that determines this maximal venous flow. And again, it's dependent upon, that is the level of blood flow at which maximal venous return occurs is dependent upon your underlying mean systemic pressure. And also, which I don't have illustrated here, the resistance to venous return. The resistance to venous return shifts the slope of the venous return curve. If you have a low resistance to venous return, the slope shifts up and to the right. If you have a high resistance to venous return, the slope shifts down and to the left, while the mean systemic pressure stays the same. Okay, and so the other half of cardiovascular physiology is the cardiac portion, and that's defined here by the Frank-Starling curve. And we're all very familiar with this, that as you increase right atrial pressure, and that's a surrogate for stretch in the right atrium, that as you stretch the myocytes, stretch of the myocytes increases troponin sensitivity to calcium, and you get a stronger contraction with a given stretch. And that is up into a point, and then you get this plateau portion where increasing right atrial pressure doesn't increase your blood flow at all. It just increases intracardiac pressure, and that puts you at risk for peripheral edema or pulmonary edema if you're measuring a wedge pressure. So this is the cardiac function curve, and this is very different from the pressure twitch graph that you may see in physiology textbooks of a single muscle fiber. And a single muscle fiber, you'll actually see stretch. There'll be an increased twitch until you get to about, I think, 2 or 2.2 microns of stretch. And then you start to have a lowering of the twitch as you increase stretch. And that is for a single myofiber. You don't see that in vivo. So people often say, oh, you've fallen off the descending portion of the Frank-Starling curve. Well, there's no descending portion in vivo. You reach your this plateau portion is defined by pericardial constraint or constraint of the mediastinum, constraint of the myocytes themselves in the in vivo three-dimensional heart. There's no descending portion that you see with a single fiber. And the other key point of the cardiac function curve that I'd like to talk about is this point here. Okay, and what I will say is, if you were to arrest circulation, make blood flow 0, and measure the pressure in the right atrium, but you've uncoupled venous return, so essentially you've clamped the IVC and the SVC so blood flow doesn't rush in, because remember I told you that if you're to measure the right atrial pressure after you've arrested circulation, you get the mean systemic pressure, which tends to be 8 to 10 millimeters of mercury. So in this situation, what I want you to do is uncouple venous return from the cardiac function and measure the right atrial pressure at 0 blood flow. You actually get a pressure that is subatmospheric. It's below 0. And so why is that? And that's because the right atrial pressure, the right atrium is a thin compliant chamber and it tracks intrathoracic pressure. So this is essentially a measurement of your intrathoracic pressure, and it's low at functional residual capacity. Okay, and this will shift with inspiration and expiration. So you can actually imagine that this point here actually tethers heart-lung interaction in terms of intrathoracic pressure. But I'm going to get more into that in a few more slides. Like the venous return curve, the cardiac function curve can shift up and down in terms of circuit function. So if you were to shift the curve up and to the left, like this, you will have a greater cardiac output for a given right atrial pressure for this curve compared to this curve. You can see here on this curve, this resting curve, at right atrial pressure here compared to right atrial pressure here, you have an increase in your cardiac output from here to here, here to here. But for this cardiac function curve, it's actually improved even more. So your cardiac output for the same right atrial pressures will increase, and that is demonstrated by an increased cardiac function, a shift up and to the left of the Frank-Starling curve. Conversely, you can have a decreased cardiac function, and so this curve is shifted down and to the right. So for the same right atrial pressures, you have a lower cardiac output, and you have actually less of an augmentation of your cardiac output, as illustrated here and here. So the venous return curve can shift, the cardiac function curve can shift. These are important concepts to bear in mind in the next couple of slides. And I've talked about this already, that this is your intrathoracic pressure when cardiac function is stopped, or when blood flow is ceased. Okay, so you may have seen this curve as well. This is the Sagawa pressure-volume relationship of the heart. And what I want to talk about now is how this curve relates to the Frank-Starling curve. So this curve essentially measures your beat-to-beat stroke volume, whereas the Starling curve is a bulk flow cardiac output for a given pressure. So let's just very briefly go over the Sagawa pressure-volume relationship. So it teases the cardiac function into diastolic function, your diastolic pressure-volume relationship. And you can see that you fill during diastole from your end systolic volume after the last contraction. You fill along the end diastolic pressure-volume relationship to your end diastolic volume, and the pressure in the ventricle has increased somewhat. Systole then begins with isovolumic contraction, so pressure goes up in the ventricle until you supersede your aortic pressure, which is essentially your diastolic pressure, or your pulmonary artery diastolic pressure if we were talking about the right ventricle. And then ejection occurs, so the volume within the heart then decreases until you meet the end systolic pressure volume relationship. And then you have closure of the semilunar valves. So this would represent essentially your dicrotic notch, this pressure here. The semilunar valves close and pressure drops to your end systolic volume, and you're ready for your next beat. And clearly it is your end diastolic volume minus your end systolic volume that defines your stroke volume. So this is one heartbeat. So then how does this relate? Again, this is one heartbeat, this is a stroke volume depiction, and this is bulk flow, blood flow. And I've tried to color code these here. That this is your end diastolic filling pressure, this turquoise, teal, blue dot. This green line will represent blood flow, or really stroke volume, because remember, stroke volume times heart rate gives you your blood flow. And let's graph these out here. So this is your Sagawa pressure volume relationship here for a given beat. This red line is actually a marker of impedance, aortic or pulmonary artery impedance, which I won't get too much into here, but I talk more about it in Chapter 2, that impedance is the geometrical summation of reactance and resistance, and reactance is related to vascular compliance, whereas resistance follows Poiseuille's law and is heavily dependent on the radius of the vascular bed into which you're ejecting, but shifts in this red curve is essentially just markers of changes in impedance. And then this is your end diastolic volume, so this is your end diastolic pressure, so this is essentially your filling pressure, your right atrial pressure at end diastole, and that would correlate with this here. And your stroke volume and cardiac output are going to correlate based on heart rate. Okay? So let's look at systolic dysfunction, impaired contractility, that patient with the poor EF, right, the chronic systolic heart failure. So they shift their end systolic pressure volume relationship down and to the right. And what happens on a given single heartbeat? Well, they're going to fill at a higher pressure and they're going to have a lower stroke volume, right? So stroke volume goes down, filling pressure goes up. How does that look on the Starling curve? Well, the curve is shifted down and to the right, assuming essentially that heart rate remains stable, because bulk flow is determined by heart rate and stroke volume. Well, what about increased afterload? Aortic stenosis or a hypertensive emergency. This patient has a systolic of 290 and a diastolic of 150. Well, their impedance is going to go way up, so they're going to hit their end systolic pressure volume relationship at a much higher pressure. Okay, so what's the consequence of that? Well, they fill at a higher pressure. Stroke volume may decrease as a result of the increased impedance. And so you really have the same physiology, that you've got a higher filling pressure for the same or reduced stroke volume. So a high impedance to flow actually also shifts the Starling curve down and to the right, or the cardiac response curve, as Arthur Guyton called it, down and to the right. And let's think about diastolic dysfunction. So diastolic dysfunction is a shift up and to the left of the end diastolic pressure volume relationship. Well, guess what? Even if the stroke volume is the same or maintained, you're filling at a higher pressure. So again, even if the stroke volume were maintained, you're filling at a higher pressure for the same or lower amount of blood flow. So bad diastolic dysfunction itself can also shift this the cardiac response curve down and to the right. And you can really make the same argument for valvulopathy as well. Mitral regurg would have a similar physiologic effect. And you can make the same argument for arrhythmias as well. If you had rapid atrial fibrillation, you're going to have less blood flow for any given filling pressure. So that would shift the curve down and to the right. So there's this kind of overwhelming thought that this cardiac response curve shifts up and down based on inotropic state only, but it's multiple factors that go into the slope and the shape of this cardiac response curve. So briefly, the cardiac function curve, we've kind of talked about this already. The x-intercept approximates the intrathoracic pressure. The slope is the overall pump function, as we just discussed in the last slide. And then the flat portion represents pericardial and mediastinal constraint. And just to reemphasize this point, in the Chapter 8 of his 1973 textbook, the late Dr. Guyton described the cardiac function, he called it the cardiac response curve, as a composite function curve for the entire segment of the circulatory system between the input of the heart and its output. Sorry, this should be its output, including, of course, both sides of the heart as well as the pulmonary circulatory system. So the slope does not simply reflect contractile state. So let's put the Guyton analysis, let's superimpose it with respiration. Okay? So intersecting the venous return curve with the cardiac function curve gives you the right atrial pressure, or for all intents and purposes, the central venous pressure here for a given cardiac output. If you were to inspire, that is lower intrathoracic pressure, remember this point here tethers intrathoracic pressure with cardiac response, so you tend to shift the curve in parallel leftwards, like this. What's happened? Your right atrial pressure or central venous pressure has gone down, but your cardiac output has gone up. And again, this makes sense in as much that the cardiovascular system is not simply a Starling mechanism, because if it were simply a Starling mechanism, you would expect a lower right atrial pressure to result in a lower cardiac output, whereas a higher right atrial pressure would result in a higher cardiac output. But it's not. It's the intersection of venous return and cardiac function that defines your cardiac output and right atrial pressure. So this is an effective increase in circuit function, like a fluid bolus. What's also important here is that you can get a visual representation of the transmural pressure, and that is the intracardiac pressure here, the pressure within the cardiac chamber, minus the intrathoracic pressure, that's the ambient pressure as defined by the x-intercept here. So your transmural pressure during an inspiration is actually increased. And remember, transmural pressure is a static pressure of the vascular system. And the static pressure the increase in the static pressure would suggest that volume is also increased, because volume and pressure are related, and it would increase as modulated by the compliance of the distensible structure. So this is the transmural pressure. Well, what would happen with an increase in intrathoracic pressure, for example, Valsalva or auto-PEEP? Well, increasing intrathoracic pressure is going to shift your cardiac function curve rightwards. So you have an increase in right atrial pressure, but your cardiac output has decreased. Again, this is not simply a Starling relationship, because the Starling relationship would predict that as you increase your right atrial pressure, you increase cardiac output, but that's clearly not what's happening here. And additionally, with the Valsalva, you've actually lowered your transmural pressure. So actually, in this patient, the volume of the right atrium or the volume of the right ventricle would shrink with Valsalva, and that's actually exactly what you see, and that's because your transmural pressure is decreasing. Okay, so let's put it all together now. So this is the thesis of all the lectures, really, and the written volume, and that is, let's have a graphical representation of heart-lung interaction. So we've got the Campbell diagram, which we talked about in Chapter 1. We've got the Guyton analysis, which we talked about in Chapter 2. They share pressure on the x-axis. They're just in different units, centimeters of water, millimeters of mercury. So let's drop the Campbell diagram, put it on the z-axis for our friends in the True North Strong and Free, and move the Guyton analysis, keep it on the x and y, blood flow on the y, pressure on the x, and as we saw, this point tethers intrathoracic pressure as defined by the Campbell analysis to the Guyton analysis. And you can see that the changes in the physiology of the lungs, as illustrated by changes in lung compliance or lung elastance, changes in the dynamic aspects of the lung, increased airways resistance, for example, changes in chest wall physiology, changes in chest wall compliance, shifting up and down to the left. can now be graphically related to cardiovascular physiology by looking at these physiology simultaneously. So the x-axis remains pressure, and changes in pressure as a function of lung and chest wall characteristics will be reflected in changes in pleural pressure, or changes of intrathoracic pressure, and how that affects the Guyton analysis is really what chapters 3 and 4 go on to deal with. Okay, and changes in pressure as a function of cardiac function and circuit function represents these changes in right atrial pressure.
And that's it for an overview of Chapter 2. And I've decided to leave you with a cliffhanger, that is the superposition of the Campbell and the Guyton diagram together as a true graphical representation of heart-lung physiology and pathophysiology. And I'm essentially certain that this will have you tuning into chapters 3 and 4 up next.